Good day, Malaysia, and welcome to another edition of The Nation. I'm Jared Ratnam, and once again, we talk about what's happening in the world of medicine. As promised some time ago, we said we're going to be talking about painkillers, and we do have a doctor who's joined us before he's back again. His name is Dr. Anbalagan Kupuswamy, and he's from the Manipal Hospitals in Klang, and he's an internist joining us to talk about pain management, or rather painkillers. And then we're going to move into pain management. We did talk about this a while ago, and we've always been wanting to do a show on painkillers. And why do we want to do a show about painkillers? Simply because most of us walk into a pharmacy or we go see our general practitioner. We say we've got aches and pains, and most of us take painkillers like sweets. So do we know what we're taking? Do we know the effects of taking painkillers? What's out there in the market? What are the do's and don'ts of using painkillers? We're going to be finding out, or we're going to try to cover all these areas as we move along in today's nation. Well, having said what I've said, let's introduce the man himself, Dr. Anbalagan Kupuswamy, who's joining us once again. Doc, thank you very much for taking time off to be with us today. Well, I'll have you know that he's also a big music fan, so at some point we're going to do a show on blues rock. But that aside, painkillers, pain management, everything about pain. Why do we need to discuss about these things? Aren't these things being talked about enough, or aren't there enough explanations out there as to what painkillers and pain management is all about?
Basically, I mean, if you look at pain is a symptom itself. All of us at some point in time in our lives had pain. Okay, and you know, there's a saying going that says no pain, no gain. So you have to have pain to get some form of gain in your life. Right. Now, pain, be it physical pain, be it heart pain, right, and be it psychological pain and things like that. So it come in all kind of facets and things like that. But here we are here mainly to talk about physical pain. But in order to understand pain, you have to have a definition of pain. Basically, from the layman's perspective, what do you mean by pain? Is defined by an abnormal sensation perceived by the body and mind. Because I stress the word mind, because people think that it's just a bodily sensation. Right. Well, ultimately, what type of pain, the duration, the extent, the severity is actually a perception by the brain per se itself. Okay. So that's in a gist is the pain is all about. Now, what causes pain? What are the causes of pain? What is the mechanism behind pain itself? So basically, you need to have a stimulus, something. We call it in medicine, we call it a noxious stimuli. Noxious in plain word means a painful stimuli, right? And once you need to have a stimuli, that is relayed by signals which are carried forward, which can either be carried to the level of the spinal cord, or they go up to the brain. And there are nerve stations there which actually receives these signals, and then they send out signals to the nerve cells at the peripheries itself. These are called pain receptors, and they set up about a chemical reaction, releasing certain chemicals, and pain is perceived. So this is basically the causation of pain itself. Of course, there are many causes of pain. So you probably have to you already define pain. You have to see what are the types of pain. You have to classify the type of pain.
Right. So when you talk about pain, we've defined what pain is, basically give you a little bit of an explanation as to what pain is. But when you move into it further, let's talk about the pathophysiology of pain. Let's first talk about the word itself, what pathophysiology means, and then probably move into that.
Basically, when you talk about pathos means it's actually a disease state, okay? And the physiology is what is the normal mechanism that sets into place in a disease environment itself. Right. So when you talk about pathophysiology, that means that's what I explained. You have to have an input. You have to have an input. You have an input like that, a stimulus, for instance. Right. For example, illnesses. Okay. You're talking about injury, or let's say certain conditions that you undergo, like an operation. All right. Which actually, let's say, for example, you make an incision into the skin. So as a result of which you are cutting into certain tissues or structures which are supposed to perceive this pain. Right. And this sets up impulses or signals which goes up to a relay station up to the brain. The brain is a big nervous structure anyway, and that it perceives, and it sends down signals down to the terminal end organs, which are actually the end organs are usually called the pain receptors. There are a couple of pain receptors. There are certain names attached to that, and then the patient will feel the sensation. All right. Of course, there are various categories of pain and things like that. Right. But this is basically the pathophysiology of pain per se.
But when you take a look at pain or the patients you meet all the time, sometimes there's no explanation to why one has certain pains he or she has. And when you work with people like this, how do you ascertain what it is they should be taking or how to manage the pain?
But to explain that, I think the rule of thumb is actually the majority of causes of pain can be ascertained. The worst of the world as far as painkillers is concerned is because what is happening now in the real world is because people are just doing symptomatic treatment. Let's say you come with a pain symptom, but what is the underlying cause that's causing the pain? You're not addressing the fundamental concept of pain causation itself. By just taking, let's say, pain relieving medication, you haven't gone to the core of the problem.
Right.
Now, to answer your question, actually, you have to classify the pain itself. In clinical context, you talk about acute pain, then you talk about chronic pain. If you attach a timeline to it, acute pain is something less than 3 months. All right.
Acute pain is less than 3 months.
That's right. And chronic pain is anything which lasting more than 3 months itself. So, and by dividing this set, so you probably can focus. So when you define acute pain, okay, a clinical scenario, just now you mentioned basically about people who come with unspecified pain, but that doesn't happen in day-to-day practice. But acute pain, less than 3 months, people who present with pain usually have some underlying conditions. All right. For example, headaches, for instance.
Right.
They are probably one of the commonest causes of headaches in clinical practice. Recurrent headaches in clinical practice is actually migraine itself.
Right.
Okay.
Right. So okay, that's what I wanted to get to. When you talk about a migraine, you can't ascertain a migraine through blood tests, and it's just through the symptoms. You talk to the patient and you find out what the patient's symptoms are. It's usually a one-sided headache, and that's classified as migraine. And that's basically just looking at symptoms. But when you want to classify it, or when you want to be sure about it, are there any tests that can be done for certain pains?
You're right. Migraine is basically a clinical diagnosis. Right? It's basically clinical diagnosis. Any other tests that are usually done in the course of a workup or a migraine, as far as the doctor is concerned, and also to allay the anxiety of the patient, is to look for something which usually lower down the order itself.
Right.
Most of the time is actually, you can tell from the history, family history, the periodicity of the headache, the type, the duration, location. Now, the tests that are being done, there are no known tests itself. Let's say if I have a CAT scan or an MRI of the brain, it's so much as to reassure the patient there's nothing sinister as a causation of headache, like a space-occupying tumor in the brain, for instance, or there is a malformation of the arteries or the veins of the brain itself.
Right.
But when you look at, we're just coming to the point, let's say if you have ascertained that this patient has migraines, and is, let's say, very often, very frequent, enough to interrupt the lifestyle of the person itself and functioning of the person. Yes, when you have an acute migraine with an acute headaches, I mean, the people who experience migraines can tell you that, all right? It's probably something which is, they're totally laid off, unable to do anything at all. Here are the painkillers, all right? Simple analgesics to start with, and then you go on to certain other painkillers called non-steroidal anti-inflammatory drugs, or to the layperson
non-steroidal
anti-inflammatory drugs called NSAIDs, for instance. They're the commonest to use it for. But that is to abort an acute attack of the migraine itself. But let's say if the clinician is astute enough to see that the frequency and the duration and the severity of the headache enough to interrupt the patient's life, then the patient should have been advised to go on some form of anti-migraine prophylaxis. These are not painkillers, these are not pain relieving agents, but they take care, undermine the pathophysiology of migraine per se. Right. These are called anti-migraine prophylactics. Why I'm saying that is, but once you educate the patient and say that you have to take this for a sufficient length of time, in spite of the fact, even though you may not have headaches itself, a parallel analogy is like high blood pressure, silent, may not have any problems at all.
Right.
But even then, you keep taking them to keep the pressure at a safe level. And anti-migraine prophylaxis is like that. Why I'm saying that is, by taking this on a regular basis, all right, one, you don't get exposed to yourself of regular use, misuse, or even abuse of painkillers. Okay, that's number one. Number two is that the frequency and the duration of headaches also come down. So that means you only keep the painkillers for instances where you really need them.
Right.
So that's one parallel. When I go back to the classification, acute pain is this kind of scenarios. People who have, let's say, migraine, women especially who have period pains called dysmenorrhea. Right?
Dysmenorrhea.
Dysmenorrhea. Certain illnesses or conditions like acute gouty arthritis. All right, or a pain, a symptom which is part of a bigger complex, like illnesses, for instance, like dengue fever. Anybody who has experience of, who had dengue fever will tell you one of the most excruciating pains that they have.
Right. It's horrible. It was backbreaking, if you ask me. But and with pain, there's also pain management. So how do you explain pain management? They've got pain management centers within hospitals. And what do these pain management centers do?
Basically, pain management, when you talk about pain management, all right, you like I said, you have to classify them into acute and chronic pain.
Right.
Then you have to find out what is the causation of the pain. All right. Number two, they are already in pain, or you're going to do a certain procedure which is going to give rise to pain. Let's say you're going for a surgery. Okay, you're going for surgery. Let's say you had your gallstone got infected, all right, called cholecystitis,
right,
and then you undergo a surgical procedure called laparoscopic cholecystectomy. So it is expected that you will suffer some sort of pain at least in the immediate 24 to 48 hours, and there you program a program called pain control analgesia. They call PCA and things like that. But these are all short-term measures. When you talk about pain management, there is a subset in the department of anesthesia. It's called anesthesiologists,
right,
who usually go on to do a pain management, a certification, and then they become pain management specialists. The role of pain management specialists comes into chronic pain, all right, which can be very difficult to manage in clinical practice. Okay, poorly understood, and you have to take a detailed history, a clinical examination. What is the underlying causation? What is the expectation? All right. What are the type of drugs that have been used before? What are the drugs that can be used at this point in time? What are the side effects that been expected with the current drug pain management? And then a realistic goal, depending on the underlying cause itself. That is it going to be 100% pain free? Right. Will I be left with some amount of residual pain? Is it only going to be 60% or 70%? So this is where the pain management comes in. So you have to take that all into consideration. Acute pain management is very simple. Like I said, a headache, or let's say if you have a viral illness, influenza, dengue, the illness will only last for a brief period, 10 days, and then the pain will going to go away. The post-operative pain, right, with a simple, straightforward surgery, is also supposed to go away if the healing is straightforward. Yeah.
Then there's cancer-associated pain.
So when you talk about a category of chronic pain,
right,
when you talk about chronic pain can be part of illnesses per se. You talk about, let's say, for example, HIV, for instance. Okay, when you talk about AIDS, when you come when the end point of AIDS, when they involve many organs, and one of because of the disease per se, or because of the treatment ascribed to HIV and AIDS itself, there are certain drugs which can cause complications called peripheral neuropathy. And pain is a very big aspect in this kind of management itself.
Peripheral neuropathy. Yeah, right.
So that's illnesses. But then when you're talking about, let's say, post-operative, you go for a post-operative thing. Let's say you had a lumbar, you had a degenerative condition of your lumbar spine, you came or you had a disc prolapse, all right? And then you went for lumbar back surgery, all right? But then it was not 100% effective. I mean, there is some residual pain associated with the A post-operative condition.
Most of the time it's like 80%.
So that has as a chronicity, something that the patient, that's as a result of a procedure.
Right.
Then you have a big chunk called cancer-associated pain, all right, which can because of the cancer per se, all right, which it affects the pain receptors in the somatic area, or the pain receptors in the visceral, the organ that is involved with the cancer,
right,
or as a result of treatment, radiotherapy, you talk about chemotherapy, all right, or the drugs that you use in certain forms of cancer, which themselves can affect the nerves,
right,
chemotherapy associated with. So that's another big entity. Then there is a very poorly defined, basically called complex pain syndromes, poorly understood, difficult to treat, and then you take it to the next level. So these are the few things that you talk about. And then the last one I want to mention is neuropathic pain.
Neuropathic pain. Well, what is neuropathic pain? We're going to take a short break. We'll come back and find out more about that. And, unclassified or poorly defined pain. We're also going to be talking about that when we come back right here at The Nation. Stay with us. Joining me in the studio today is Dr. Anbalagan Kupuswamy. He's an internist from the Manipal Hospital in Klang. We'll be back shortly.
I travel not because I like to travel. I travel so I can say this. What you're looking for is inside of you, and you should be in peace.
Prem Rawat has been traveling for 40 years, inspiring people around the world to find peace within.
I go and I talk to people, and I present them with the possibility of themselves discover the peace that lies within you.
Kavita, Meling, dah set ke belum?
Sikit je lagi, Puan.
Apa menu kita hari ni?
Semua menu sihat. Ikan bakar, sup ayam, sayur-sayuran. Banyaklah.
Puan, banyaknya guna minyak. Bahayakan kesihatan lah.
Betul lah macam ni. Saya dah kurangkan separuh dari biasa ni.
Cuba rasa ni. Sedap tak?
Biar kurang masin, jangan lebih.
Betul tu. Kita kena kurangkan minyak, gula,
garam dan santan dalam masakan. Barulah ramai pelanggan datang ke kedai kita.
Semuanya
sihat belaka.
Menyelami realiti, menjejaki masa, meninjau peristiwa, paparan kronikal kembara kehidupan, pelbagai keunikan juga pengalaman menarik. Segalanya disorotkan selama setengah jam dalam channel bernama setiap Ahad jam 9.30 malam hanya di Bernama TV.
Hello Malaysia and welcome back to The Nation. I'm Jared Ratnam, and today within The Nation we're talking about painkillers and of course pain management. Joining me in the studio is Dr. Anbalagan Kupuswamy from the Manipal Hospital in Klang. We've got something for you here. Of course, we're going to take a closer look at painkillers. Some of us take it in the city. There's a saying that some of us take it like kwachi. So we're going to understand what this is all about. Most of us buy painkillers and we take them all the time. We are only treating the symptoms, not the cause of the problems, as was said by Dr. Anbalagan. But before we get into talking about the painkillers, let's find out what unclassified and poorly defined pain is all about.
Neuropathic pain.
Neuropathic
pain.
Neuropathic pain, yeah.
Now, basically, I'll start with the neuropathic pain itself, right? Something that we see quite commonly in clinical practice itself. Malaysia right now is under a big cloud of type 2 diabetes mellitus, keeping up with the ways of the world, the lifestyle, the eating habits of the population itself. And in clinical practice, long-standing diabetes, or more than 10 to 15 years, we see a complication called neuropathy, especially a thing called peripheral neuropathy.
Right.
To the layperson, neuropathy means basically disease of the nerves. It can be peripheral, means in the peripheries, classically glove and stocking. That means your toes and your fingers itself. In spite of the fact that if your control can be exemplary, that means that you lead a very saintly life, your sugars are very well under control and things like that. 40 to 60% over a course of 10 to 15 years can develop this. Okay. And it can be very debilitating.
Right.
All right. It can affect the mind and the body of the person per se. And this is what we call diabetic neuropathy. Of course, it can affect both the sensory nerves as well as the motor nerves itself. And there are options for that. Okay. Of course, the rule of thumb is to make sure that your diabetes is actually very well under control. But we've seen even people who seem to have very well controlled. So paradoxically, sometimes the neuropathic pains can get worse. And there are certain roles besides, of course, taking care of the blood sugar itself and other allied factors allied to the diabetes, whatever you call hypertension and the raised cholesterol itself. When you talk about nerves itself, we use certain form of medication. The things are basically called antidepressants.
Right.
Now, people will get some of them might get a bit perplexed and astounded as why do you want to use an antidepressant in the role of pain management, especially as far as nerves are concerned. Antidepressants, and especially a classical example, old antidepressants, it's been here for the last 30-40 years itself, cheap and also effective. It's called amitriptyline. Okay, amitriptyline. Of course, there are a couple of other drugs allied to that, but this is something that we use, starting with a low dose of 10 milligrams itself. And they are all wonderful agents, all right, that been used. And of course, the side effect, of course, you have to start slow, start low, and especially bedtime, right? The common side effects is that people usually become complex sedation, dry mouth. You got to be careful, let's say in elderly men, especially who have some form of bladder obstruction, let's say got prostatic hypertrophy. So this is where one form of neuropathy. This is commonest that we see here. Another thing is social status, okay? People or social class, people who have social habits like alcohol, for instance. People consume a lot of alcohol for a long length of time. They also develop a condition called alcoholic urethritis. But there, the treatment of choice is, of course, besides abstaining from alcohol itself, paradoxically, you don't use a painkiller. You use a drug called thiamine or vitamin B1. Right. So this is one facet of neuropathic pain. The other common neuropathic pain that we see in clinical practice, especially in the elderly age group, more than 50 years of age, who happen to contract an illness called herpes zoster. Herpes zoster is basically a chickenpox virus.
Right.
In young children, you get it as chickenpox. In elderly people, you can get it as zoster.
You get it sometime on your lip.
That is herpes simplex.
That's herpes simplex, not herpes zoster.
Right. Okay. You can get it too in the lips, but then it comes according to the distribution of the nerves itself. You can. Okay. That is zoster of the of your jaw or your cheek and things like that.
So shingles would be herpes.
That is herpes zoster. Yeah. Now what are the commonest things that we see? Let's say if the zoster has not been treated promptly, right, that we see, especially in the elderly age group, is actually a condition called post-herpetic neuralgia. All right, the skin lesions must have gone away, the skin is probably back to normal. But what happens is this virus or virus particle virions, they reside the back of the spine in the ganglia itself. All right, and it leaves a very devastating effect on the peripheral nerves. Okay, I've seen elderly people crying, depressed. Even people even have suicidal ideation, things like that. All right. So here we use a group of drugs called anticonvulsants. Anticonvulsants in rare people is drugs that you use to control epileptic seizures. All right. Originally marketed to control epileptic seizures, but they also have been expanded, licensed for neuropathic pain. A classical example is a drug called gabapentin. All right. That's number one, and marketed as Neurontin, all right? And there's another drug called pregabalin, which is actually marketed as Lyrica. So these are the two common things of, let's say, neuropathic pain. We also have, let's say, cancer-associated pain. Cancer-associated pain can also be neuropathic pain if the cancer tissue has invaded local neural tissues, or you have done surgery to remove the cancerous tissue, and in the advent, you also have, let's say, cut across and severed certain nerves which have not regenerated or regenerated aberrantly. Okay. Now the fourth thing, when you said about a condition called, let's say, poorly unclassified, poorly defined or unclassified pain. And for example, let's say if I undergo an amputation of the leg, all right, and that the wound is healed or scar is formed, but there is a perception in the mind of the person that leg is still there. We call it a phantom limb, saying that is still painful, things like that. So this is actually very poorly defined. This actually is a mindset of the patient itself, right? There is another entity called, people have strokes, called brainstem strokes, called a thalamic syndrome, where on recovery, they may not have any neurological deficit except as one side of the body itself has got a heightened sense of pain, called hemi-hyperpathia. Right? So these are some of the things that are, you can't put a button to it, poorly defined, not very well responsive to treatment. So there, it's not only painkillers. You have a multimodal approach to pain relief itself.
You're talking about pregabalin and the other one was gabapentin. When you use painkillers like this, can they be classified as painkillers too?
No, they are licensed. They are licensed as anticonvulsants. All right,
and they are licensed as anticonvulsants.
And expanded. They're expanded because they have done trials and they've proven, and they also licensed. You can see in the literature itself, they will tell that is also indicated for the use, let's say, post-herpetic neuralgia, polyneuropathies. They do that.
Right, and with drugs like this, when you go online and read about people who are using this, most of them complain about not being able to, they feel sedated throughout the day with anticonvulsants.
Especially if you use it in the elderly population. So it's, of course, the dosing schedules, because it's all done in a white man's world, basically. I'm sorry about that. Caucasian population, all the population that was done at that point in time itself. We Asians sometimes can differ. I mean, you have to individualize. And the rule of thumb is always start low.
Right.
Low, start it at night time. You will know that gabapentin can cause sedation, can cause dizziness. So that's why we say we take it at the night time, I mean, when you go to bed.
Right.
And then you try to titrate the dose. Let's say the dosage, each capsule of gabapentin is 300 milligrams. We start at 300 milligrams at night time, and then we titrate and see, and then we introduce in the daytime. It's about 300 milligrams 3 times a day, but we usually don't do that, especially the elderly population, because it will defeat the very purpose when they come back the next day and say, look, I'm not confident to take this medication because you didn't advise me about that. So that's something. Like pregabalin, for instance, same thing. The dosage that's marketed is 75 milligrams. But we start with, let's say, a lower dosage, and there are marketing for 50 milligram. They can cause some, swelling of the ankles. But this is what the practitioner should know.
Right.
And this again was very important, that you don't walk into a pharmacy and say that you have, and then you buy it from it. It's very important that you check with your regular medical practitioner.
Right. With regular medical practitioners, that's another problem too. Are they well versed with these stuff or these drugs? We'll come back and talk about that shortly, and also give you a list of drugs. We've got some drugs that we're going to show you too, or rather our painkillers that we've brought. We're going to show you the various painkillers being sold in the market and what they can do for you, and what you shouldn't do with these painkillers, and things we need to know about painkillers, especially if we're going out and buying them from pharmacies. Stay with us right here at The Nation. I'm Jared Ratnam.
Current issues, latest headlines, illuminating visuals, everything right and now on Bernama News.
Sedar tak kita, tuan-tuan dan puan-puan, keadaan iklim yang tak menentu sekarang ni. Perubahan iklim meningkatkan kejadian kemarau, derebu, banjir, dan ia menyumbang kepada perubahan iklim yang berlaku secara drastik. Inilah dia faktor-faktornya. Yang pertama, asap dari kenderaan. Yang kedua, penebangan dan pembakaran hutan. Yang ketiga, pembebasan asap dari industri perkilangan. Dan yang keempat, pelupusan sisa buangan. Ini usaha yang Pak Abu buat, iaitu yang pertama, menanam pokok. Yang kedua, mengurangkan atau tidak menggunakan beg plastik. Yang ketiga, mengasingkan bahan buangan. Yang keempat, mengitar semula bahan buangan. Dan yang kelima, memilih barangan dari bahan kita semula. Ada banyak lagi usaha yang boleh kita lakukan. Antaranya, kurangkan pemanduan kereta persendirian dan banyakkan penggunaan kenderaan awam.
Anda adalah sebahagian daripada penyelesaiannya.
Menongkah batasan masa, mengupas isu semasa, jadi saluran pelbagai suara. Segalanya baru dan benar di Berita Bernama TV.
Welcome back to The Nation. Thank you very much for staying with us. I'm Jared Rutnam, and at The Nation today we're talking about painkillers and pain management. We're now going to move into the various painkillers you would be able to find, or you should be able to find in every pharmacy. Most of us go out and buy painkillers, and one of the most famous, well-known ones is paracetamol, and there's the ibuprofen. Now we've got two of this here. I don't know if you can see it. If you can close it, bring the camera a little closer, we can show you. Of course, everyone knows what paracetamol is. I haven't seen it before. But having said that, with paracetamol, there are many different types of paracetamol. Now, the paracetamol for osteopain, for women's monthly problems. What's the difference with these paracetamols? Is there a difference? And be honest with us.
Well, I will just briefly talk about the pharmacology of pain. All that. Now, like I said, now if the practitioner has decided that you need to take drug therapy for pain relief, right? Always start with something very simple: the tried and the trusted. Okay, minimal side effects. That's basically that.
Right.
And one of the most prescribed items in this globe right now is paracetamol.
Right? I have it here.
And because it's a non-prescription item,
right?
I mean, you don't need a doctor's prescription for that. And I think they've already extended to the other painkillers like brufen, okay, ibuprofen, right? And also some parts of the world they've also given status to naproxen,
right?
Another pain relief medication. Now, to come to you to your answer your question of paracetamol,
right?
Very cheap, very effective. Must be taken at least about 3 to 4 times a day, right? Because it's short half-life itself,
right?
Okay.
Right.
Mechanism of action. It has action basically also in the brain, in the region of the condition called the hypothalamus itself.
Right. So this is paracetamol, and this is brufen.
Yeah.
And the difference between these two, as you were saying?
Well, basically, paracetamol is actually what is a different class altogether. It's called phenacetin group of medication. The mechanism of action is not very well understood. But when you talk about brufen, brufen belongs to a class of drug called, just now I mentioned, called NSAID. NSAID. It's called non-steroidal, obvious because it's not a from steroid. Anti-inflammatory, because it acts against anti-inflammation drug. Now you would ask me why an anti-inflammatory drug is used as an analgesic. Here, the mechanism of action of, let's say, brufen itself, basically, it acts on a chemical called prostaglandin, which are supposed to be the chemical mediators of inflammation, which thereby which triggers off a chain of reaction which causes pain and inflammation itself. So by suppressing these prostaglandin synthesis inhibitors, all right, pain is reduced. So this is actually a group. And in brufen, it's one of the ones which are commonly used, all right?
Right.
But you must understand that in clinical practice here, it is just not basically used for a painkiller mechanism. Brufen is also other actions because of antipyretic, just like paracetamol.
Right.
All right. In paracetamol here in Malaysia, you probably use it more for its fever reduction properties rather than pain relief per se. All right. And ibuprofen also does that. So it has got antipyretic, that means pain reduction, anti-inflammatory, fever reduction is antipyretic, pain reduction is anti-inflammatory.
So you would say that Brufen is more all-round.
That's right. That's right. So let's say if you have pain, let's say musculoskeletal pain.
Right.
Let's say you have joint pain, for instance. There, you probably
Speaking of joint pain, I can feel it already. Yeah.
You probably use Brufen per se. But then, having said that, I think when you prescribe drugs like paracetamol or Brufen, of course, Brufen is only one of the long list of a humongous group of non-steroidal anti-inflammatory market that has flooded the market itself, and the list can go on itself.
But I mean, lay people as the Joe public, when we talk about painkillers or anti-inflammatory, you talk about Brufen, paracetamol. Every time a friend, you give to a couple to a friend and say, hey, be careful, take too much, it's not good for your kidney. How much truth is there in this?
Yeah, good question. Good question. You're not supposed to take more than 4 grams a day.
4 grams a day.
I'm talking about an adult, okay? Of course, the pediatric dosing is actually, you have to calculate according to the body weight itself. Each tablet, standard prescribing tablet of paracetamol is available at 500 milligram tablet. Right? So if you're talking about 500, you're talking about 8 tablets more than a day, and you don't want to consume that more than 7 to 10 days.
Right.
If you continue to have pain, that's very, very important. Go back to your practitioner and see why your pain is not resolved. Is there any other underlying cause, or the initial process which triggered or caused this pain is actually relentlessly progressing? So that's the most important thing.
Right.
And most so, okay. And in paracetamol, because they said that paracetamol somehow or other it's been much maligned. The commonest thing that I have friends coming over and say, what happened? I waited 4 hours in an outpatient queue in a general hospital, and you know what that guy gave me? He just gave me Panadol.
Yeah.
All right.
Yeah.
And somehow or other, you've given it.
I'm guilty of this too. You come out you come out of the hospital and you're just so out of it, and you're just so upset because you went in there, the doctor spoke to you for half an hour, they did this, that, and they sent you home with paracetamol.
No, but like having said that, much malign it is. It's a very useful agent. It's a useful agent.
We're Malaysians. When we go to a doctor, we want to come back with different medicines of different colors and different types. It looks all so interesting. Wow, new one.
No, but the thing is, sometimes they don't say it's Panadol. They say it's KK.
KK,
Kementerian Kesihatan. For all you know, it might be some other medication too. But somehow or other, it's the mindset that the KK is, means it's paracetamol. Things like that.
So when you talk about paracetamol, the different brands, and there's the one given by the general hospital. Some people want the KK ones because they believe that the KK ones are the best. And is there a difference in grade with paracetamol?
No, they're about the same. It depends in preparation. It's just preparation, manufacturers and things like that. Like you said now, like I use it for, let's say, osteoarthritis. You have extended release paracetamol. Sometimes they are coupled with another group of analgesic, like an opioid, for instance, a low dose tramadol plus paracetamol called Ultrasap itself. Then you have also menstrual, paracetamol for menstrual, paracetamol for cough and colds. So you have soluble paracetamol. So I think it's basically, it's just a gimmickry. I mean, basically a selling point to say that certain various facets of pain management for different kind of groups, different kind of sexes, be it whatever condition. Basically, it's a marketing plot.
You know what's going to happen? I think in time to come, the normal paracetamol will be classified or sold as paracetamol classic because we've got just so many in the market now. Well, from there, let's move on to we're done with paracetamol and Brufen. What else do you have to show us today?
Now, of course, just a little bit. I'll touch on the paracetamol itself.
Right.
Much as it sounds, as it's safe it can be, there is a subset of people, subset of people who have to be cautious when they take paracetamol. There are studies to say that over a long period of time, you just ask them, how much can I take in a day, how many days can I take, and things like that. People have consumed more than 1,500 tablets in a lifetime. They are also at risk, for kidney disease.
1,500, so that's
analgesic nephropathy, they call that. And people who, let's say, who got chronic liver disease for whatever cause, people who take any other medication, which let's say will interact with paracetamol itself, they can cause liver disease. And one of the commonest emergency room visits for overdose or poisoning is paracetamol in this country.
Right.
All right. A very commonly used drug for suicide or parasuicide. So
right.
let's
Yeah.
not forget that.
But why did they use it for suicide? I had a friend in school who apparently used paracetamol, loads of it, for suicide. But he attempted it, didn't happen. But why is paracetamol the drug of choice
Probably
for suicide?
it's much easier to get, and probably it's always around in the household. Every household probably has some. You have some, Panadol with you. You stay at home. You go to work. You travel. You ask your friends. Everybody will have their quota of paracetamol with them and things like that. It's a part and parcel, just like how you take 3 meals a day and things like that. Maybe that's one of the reasons.
My first understanding of why people use paracetamol for suicide is because they want to relieve all that pain before they say goodbye. But apparently it's not like that. So what else do you have for us with regards to paracetamol before we move on?
No, that's paracetamol. Let me go to the NSAIDs for sure.
Right.
We could talk about NSAIDs. Now, when you talk about NSAID, we talk about Brufen, like I say. But from Brufen, there's a chain of other drugs which I have not mentioned. We talk about indomethacin, we're talking about naproxen, for instance, all right? Ketoprofen, and things like that. And one of the biggest fears and policies that we have in NSAID, chronic NSAID usage, is because it can actually can destroy the gastrointestinal lining, taken for a long length of time, especially people who are predisposed to gastric problems, gastritis, or peptic ulceration, things like that. And those 20 years ago, one of the commonest thing in an emergency room, person who presents with an upper gastrointestinal bleed is actually NSAID ingestion, chronic NSAID ingestion. To obviate that, all right, what they did, the pharma industry came out with another group of drugs to say that the toxicity, the GI, gastrointestinal toxicity profile is much more lower. The inherent risk associated with this particular group of drugs less. These are called the coxips, of which we have in the market right now called Celecoxib, marketed as Celebrax. All right. There's another drug called Etericoxib, which is also marketed as Arcoxia. Sad to say now, some or other, the middle class, the upper middle class and the affluent seem to have found great favor with drugs like Etericoxib and Celecoxib. That seems to be the painkillers of the moment right now. But sad to say, please, whenever it's indicated, whatever time you use that, there is a point in time, let's use it for a brief point in time to take care of the situation itself. You're not going to take Etericoxib, Celecoxib for a long length of time. All right? No matter what the manufacturers say, no matter what your condition is. All right? To give you a parallel, let's say I got inflammation of the joints called rheumatoid arthritis. The basic thing is actually in the joints at synovium, affecting the cartilage and the capsule thereafter. All right? Chronic, progressive, or debilitating disorder itself. There, of course, the mechanism is actually pain relief, anti-inflammatory. So one of the commonest things that's prescribed by a rheumatologist or your private practitioner will be an NSAID. All right, but long length of time NSAID consumption, these are some of the side effects. They can affect your stomach, they can affect your kidney, can affect your liver and things like that. So, but my talking point is that you have to go into the underlying pathophysiology of the rheumatoid arthritis per se. All right. Now, there are certain drugs called disease-modifying anti-rheumatic drugs itself. So, if a point in time you have used, let's say, as a first line, or depending on the status of your disease, and a severity of your disease and certain criteria and things like that, if you think that this is going to progress, you have to go on to specific remedies for the rheumatoid arthritis. So that's what I'm trying to say. Right? Okay, basically that. Though although the coxips as touted as GI friendly, but they didn't say that there is zero effect on the GI itself. Right? And it is GI friendly to a certain point, not when you're taking 10 to 15 a day, or 10 to 15 a week. But if you head on, which probably a lot of people don't know, if you take head on with a standard dosing of an NSAID, let's say for naproxen or diclofenac, with a standard dosing of Celecoxib, in potency, in pain relief, in fact, the much cheaper version of NSAID is probably far superior as far as the coxips, which are actually relatively expensive. That's number one. Couple of years ago, there was a drug called Vioxx is marketed as Vioxx,
Yep,
okay,
yep.
and Rofecoxib, things like that. Came with a bang, came with a flash.
Right. I'm going to hold you to the Vioxx. We're going to take a short break and come back and find out about ending backaches and starting heartaches. We'll come back and talk about Vioxx and a couple of other drugs in a short while, or rather painkillers, right here at The Nation. Stay with us. Jared Ratnam with you.
Terima kasih. Sama-sama. Terima kasih. Sama-sama. Sama-sama. Terima kasih. Sama-sama. Sama-sama.
Satu cerita, satu bangsa, satu Malaysia.
Halo, apa kabar pemirsa? Salam dari Jakarta. Sebuah program kerjasama Kantor Berita Indonesia Antara dengan Kantor Berita Malaysia bernama kembali hadir menjumpai Anda.
Welcome back to The Nation. We're talking about painkillers and pain management. We talked a little bit about pain management. We're talking about painkillers. We just spoke about paracetamol. We talked about Brufen. We talked about NSAIDs. Now, this is, when you want to see dead people, you take this. This is called Tramo. And a lot of people hate taking it. A lot of people who use this for pain management say it's horrible, side effects are terrible. Can you tell us a little bit about this drug?
Well, Tramol, I mean, that's a trade name for it, but it's actually called Tramadol.
Tramadol.
It's marketed as an injectable. It's also in a capsule form, right? Very commonly used in these parts of the world, right? It's classified as an opioid.
Opioid. As opposed to an opiate.
Opiate, yeah. Opioid are chemicals or drugs that can work in like an opiate-like manner. All right. And they act on receptors called opioid receptors. So to give you an idea of where it's a derivative form, the mother of all derivatives is actually the poppy, the opium. All right. From one is harvested, and the king of all the painkillers, morphine, is extracted and synthesized.
That's the king of all painkillers. Yeah.
And in the other, they're called opiates. And from morphine, you also have codeine, much less potent, available in tablet form. Now, what happened was that they went back to the lab to they already have the basic chemical structure. So what they do, they have a synthetic or semi-synthetic manufacturing, all right? And they came with this class of drugs called opioids. Opioids. Now, if you look at the chain of order in pain management, and where does opioids stand? You probably want to give it for moderate to severe pain in clinical practice itself. But it is not without side effects, all right? Okay. But now, the commonest side effect that we encounter is actually nausea.
Nausea would be the main side effect.
Yeah, one is nausea. And respiratory depression. So you got to be careful dishing it out of people who got chronic lung problems, chronic obstructive airways disease, people got, let's say, unstable asthma, all right? People with obstructive sleep apnea syndromes who have daytime excessive sleepiness. So you got to be careful about that, right? And besides this too, all right, constipation is always a big issue. I see a huge number in of elderly population who are dished out tramadol, come with constipation. So these are three common things that we see in practice. Now, they are actually moderately effective for pain relief itself, right? You have to take it about 3 to 4 times a day, right? Because they're short half-life. They have now come out with extended relief preparations of tramadol too. And what they did was, because when they use standard dosing, people have side effects. So what they try to do is they give lower doses coupled with another analgesic of a different class. So now opioid, like tramadol, is co-mixed with a paracetamol and marketed under the name of Altracept. Right? Now, besides its pain relieving properties, all right, and the side effects in itself, one of the commonest things that we see in practice is actually its addictive properties. You must understand, when you talk about pathophysiology of pain, all right, these painkillers also, what they do, they also stimulate part of the brain, the area called pleasures of the brain. So what they do is, they heighten the pleasures, make you into a state of euphoria. So whether you want to take it for analgesic property or pain reduction, or whether for euphorian, over a period of sometimes it gets clouded. So much so people start missing the euphorian effect of the medication itself. And then you develop addiction for the medication, you develop physical dependence, and that is one of the real dangers of, let's say, abuse and misuse of this drug.
But tramadol has an important place in pain management, and it should be prescribed by a doctor.
If used appropriately, adequately, with the knowledge of the side effects and the contraindication that the practitioner as well as the patient is aware. Yes, it definitely has a role to play.
Right. We've got less than 4 minutes. Is there anything else that you want to show us before we get a take-home message from you with regards to painkillers and, of course, pain
I think
management?
basically the Malaysian population per se, is actually, we are only dealing with two aspects of it. One is the NSAIDs, which they can buy liberally from the pharmacies. The opioids, it's a prescribable item. That means it's a prescribed painkiller. So you probably, any responsible pharmacist will not sell you a tramadol without a proper prescription, things like that. So all painkillers have a definite role, very, very useful, all right, if used appropriately and correctly, all right. There is a lot of misunderstanding about painkillers, all right. There is certain quarters can abuse painkillers for the wrong reasons, like codeine, for instance, which is administered in cough syrups because they wanted to get a high because of the euphorian effect. But actually, it was actually marketed initially for its painkiller effect itself. So let us all be responsible citizens, both the practitioners and the patient. Be aware, and then the most important thing is, why do I need a painkiller? What is the underlying cause of my pain? So these two, you have to ask yourself a question. I think you need to take, as a consumer, you have to know, and it's every responsibility of every practitioner to answer these two questions.
Right. So when you go to your doctor, when you go to your physician, when you go to a specialist, and they say take this. This is for pain relief, and sometimes they're usually generics, and you don't know what the brand name is. You just take it home, and you take 2 or 3 a day as prescribed by the doctor. If you don't understand what it's all about, please make them help you understand it. Their work is to make sure you understand what you're taking in it.
That's right.
That's right. And if you still don't feel comfortable with what you're taking, go back and ask for an explanation. Most of us don't want to ask for an explanation. We don't even know what painkillers we're taking. We just pop them, and when the doctor gives it to us, we take them home, and we take them every time we have pain, but we don't know what we're taking. And it's very important that you understand what you're taking at all times.
One last word, second, because this is something that I see every day in practice, and it frustrates me. The fact that a lot of practitioners, what they do is when they give out prescriptions, general practice, and I don't mean to malign them. What they do is when they give out, please write the name of the medication on the plastic sheet which they dispense and things like that, because like you said, now there are umpteens of generics on the market. So and the Malaysian population doesn't ask a lot of questions when it comes to the practitioner. They are wholeheartedly and
every time our doctor says something, we're like, okay, doctor, I'll go back and do that.
Please make sure that your practitioner writes into the prescription the name of the medication, because in the event that you don't get well, you want a second opinion, or you get hospitalized, it's much more easier for the subsequent practitioner to know what he or she was given in the first place.
Right. On that note, we'd like to thank you, Dr. Anbalagan. It was a pleasure having you back again.
Thank you very much.
The next show you're going to do is going to be a blues rock show.
Thank you. You made my day.
Well, Dr. Anbalagan Kupuswamy from the Manipal Hospital in Klang, talking about painkillers and pain management. We hope at some point or some stage we'll be able to do a part 2 on this. Thank you very much for staying with us right here at The Nation. I'm Jared Ratnam. You have a great day ahead.